Hi everyone, welcome back. Let's go through an EKG challenge. This is our today's electrocardiogram, taken from a 52-year-old female, known case of diabetes, presented to emergency department with recent onset of dizziness and weakness. On physical examination, she had bradycardia. An EKG was obtained. What do you think about this tracing? What is your plan? As we already said, always apply the 10-step approach when interpreting any strip. First, start with the EKG speed and voltage, using the standard values or calibration marker. Here, the calibration marker is 2 large boxes tall, and 1 large box wide. Therefore, this strip is standard. Second, determine the cardiac rhythm. As you might know, there are 3 main steps to interpret every heart rhythm. 1. Locate and examine P-wave morphology. Here are the P-waves. They are morphologically uniform and identical. So all P-waves are originating from a single focus. The P-waves are positive in D1, D2, V3 to V6, and negative in AVR. Therefore, P-waves are sinus. 2. Locate and examine QRS complex morphology. In this strip, only 2 beats are recorded. As you see, the first QRS complex is narrow, but the second one is broad. So, we have 2 types of QRS complexes due to intermittent QRS widening. Remember that, when there is intermittent broad QRS complex, 4 main differential diagnoses must be considered. 1. Intermittent bundle branch block. 2. Intermittent WPW. 3. Intermittent ventricular pacing. And 4. Occasional ventricular beats. In this case, the P-wave is very helpful in distinguishing these 4 differential diagnoses. If a P-wave precedes QRS complex, intermittent bundle branch block or intermittent WPW is the case. Here are obvious P-waves preceding the QRS complexes. So, ventricular pacing and ventricular beats is not probable. On the other hand, there are no delta waves. Therefore, the cause of intermittent broad QRS complex in this strip is intermittent bundle branch block. 3. Describe the relationship between the QRS complexes and P-waves, using P-QRS ratio and intervals, including RR interval, PP interval and PR interval. Here, there are non-conducted P-waves, inferring that a sort of heart block exists. Every other P-wave is not followed by QRS complex. Therefore, the ratio of P to QRS is 2 to 1. So, we have 2 to 1 AV block, which is a kind of second-degree AV block. As the name implies, the ratio of P-waves to QRS complexes is 2 to 1. In general, fixed ratio block, like 2 to 1 AV block, can be the result of either Mobitz type 1 or Mobitz type 2. On the other hand, the PP interval, RR interval and PR interval are stable. Therefore, the rhythm is regular. In summary, the underlying heart rhythm in this patient is sinus with 2 to 1 AV block, and intermittent bundle branch block. Third, calculate the heart rate. The RR interval is approximately 8.5 large boxes, so the heart rate is nearly 35 beats per minute. Fourth step is axis analysis. Here, the QRS complexes are positive in lead 1, but negative in lead 2. So, left axis deviation is present. In this strip, left axis deviation is due to left anterior hemiblock. Fifth step is examining the P-waves. As we already said, the P-waves are sinus. Both amplitude and duration of P-wave is 2 small boxes, so no LA or RA abnormality exist. Next step is PR interval. Here, the PR interval is about 3 small boxes. Remember that, when second or third degree AV block is present, the value of PR interval is no longer helpful in determining first degree AV block, because second degree AV block is superior to first degree AV block. So, we can somehow skip this step. Next part is QRS complexes. As usual, examine 4 items to determine the QRS complex changes. 1. QRS duration. As we said before, there is intermittent QRS widening due to intermittent bundle branch block. The wide complexes have RSR prime pattern in V1. So, the bundle branch block is due to intermittent RBBB. 2. QRS amplitude. As it is clear, the complexes are neither low nor high voltage. So, the QRS complexes have normal voltage. 3. R wave progression and transition zone. As you see, the transition zone of narrow complexes is delayed, and occurs in V6. Delayed transition is due to left anterior fascicular block. 4. The final item in this step is looking for pathologic Q waves. There are just small septal Q waves in D1 and AVL. Septal Q is a normal finding in lateral leads. In summary, the QRS complexes have poor R wave progression, due to left anterior hemiblock, with intermittent RBBB. Next part is examining STT changes. Here, there is no obvious ST elevation or depression. The T waves are negative in AVL and AVR, flat in D1, and positive in other leads. Remember that isolated T wave inversion in AVL is a normal variant. So, there is no significant STT changes. Next part is QT interval. Here, the QT interval is about 13 small boxes, so the QT is 520 millisecond. The heart rate is 35 beats per minute, so according to the Hodges formula, the corrected QT interval is 477 millisecond, and therefore is slightly prolonged. These are the reported causes of long QT. As you see, electrolyte and metabolic disturbances, medications, bradyarrhythmias, myocardial ischemia, and finally, congenital syndromes are possible causes and potentiators of long QT. In summary, the prolonged QT may be due to underlying bradyarrhythmia. But it's better to check electrolytes level, including potassium, calcium and magnesium. The last part is overall interpretation. Before going through this part, if you have enjoyed this video till now, please subscribe me and ring the bell for further videos. To interpret our EKG properly, we are supposed to make a list of abnormal findings. In this strip, the abnormal findings are 2 to 1 AV block, intermittent RBBB, bradycardia, left anterior hemiblock, and slightly prolonged QT interval, possibly due to bradyarrhythmia. The presence of second-degree AV block, with RBBB, and left anterior hemiblock indicates possible trifascicular block. So, this case is a kind of trifascicular block. Let's go through a couple of clinical tips about heart blocks. The initial management, in patients with second-degree AV block, depends on the presence of signs and symptoms. If the patient is symptomatic and hemodynamically unstable, urgent treatment with atropine, and temporary cardiac pacing is necessary. But, if the patient is symptomatic and hemodynamically stable, like our case, urgent treatment with atropine, and temporary pacemaker is not indicated. Instead, the patient must be continuously monitored with transcutaneous pacing pads. Remember that, in AV blocks, we should always exclude potentially reversible causes of AV block including myocardial ischemia, myocarditis, medications, electrolyte disturbances and hypo or hyperthyroidism. Note that, if no reversible etiology is detected, all symptomatic bradycardias like our case, require implantation of permanent pacemaker. Thanks for watching this video. If you liked this video, please subscribe me and ring the bell for further videos. Have fun!